Dr. Barragry is the Senior Veterinary Pharmacologist at the Veterinary School in University College Dublin. He qualified in veterinary medicine from Dublin in 1971, acquired his master's degree in pharmacology in 1974, and his PhD in veterinary pharmacology in 1981. Both these theses were concerned with pharmacokinetics in animals. In 1998, he was made an honorary diplomat and specialist of the European College of Veterinary Pharmacology and Toxicology. In 1994, he published a sole-authored textbook, Veterinary Drug Therapy. This book has become the recommended text in many veterinary schools in Europe and the US and is widely cited in veterinary literature. He's made numerous other publications. He's been a member of the Irish Regulatory Authority, the Irish Medicines Boards for many years, and has been on the panel of experts of the European Medicines Evaluation Agency. Dr. Barragry's topic is variations in levels of NSAIDs in horses. Thanks, Tom.
Thank you, Chairman. And Your Royal Highness, ladies and gentlemen, and thanks to the FEI for the invitation to speak here today. Very happy to be here. Variation in levels of non-steroidals is a big ask because this is an area of variation of drug response is one of the growth areas in pharmacology. And I suppose the one message I want to put across here this afternoon, albeit very briefly, is that one size does not fit all, and that no two animals react in the same way to the same dose of the same drug. If I can get that message across, I'll die happy. And I just want to illustrate here a quote at the start, which I like. Mass market drugs have successfully treated millions, but they have a corollary. One size has to fit all. Every patient gets the same drug, yet every patient is different and responds differently to drug treatments and doses. Each drug, each dose, each treatment will be tuned not to the average patient, but to the individual. It is the difference between an off-the-peg suit and one made to measure. Now, that's a quote from an old friend of mine, Lester Crawford, who I'm sure some of you here know quite well. So we're looking at variation here in response to drugs. And why does drug response vary? Where we have the same symptoms, the same findings, the same disease, we have different horses, they're given the same dose, same drug, different response. Possible reasons, obviously, will be in here, individual variation and PK/PD differences, differences in pharmacokinetics and pharmacodynamics, how the drug acts and how the body handles the drug. And these are driven by a number of other factors. There we are. Variables that come into the pot here would be the breed of the animal, the age, and we deal with different ages of horses, obviously, breeds, pregnancy perhaps, disease, and also drug interactions, which I'll mention briefly. A huge area, a huge growth area was touched on this morning, and this is the genetic effect. And pharmacogenomics is one of the big drivers of the pharmaceutical industry in the future and one of the big areas of research, because adverse reactions to drugs is now a major area, and we live in a very litigious society where adverse reactions are far too common. Drug companies are feeling the pinch, and there's a great deal of research being driven into this area of inherited metabolic effects and so on. So genomics is a huge one here. There's been a complete raft of papers published in recent years. We know they're at the very top, variations in response to non-steroidal anti-inflammatories. Of all groups, of all drugs, these are the drugs where we see amongst the greatest individual variations. It's been widely written about for 25 years or more now. And for a long time, this was just looked at as, well, that's the way it is, isn't it? Now, we're looking more about the genetic impact, and there are more and more papers coming out on genomics and pharmacogenomics, inheritance of drug responses, and here we have genetically mediated variation in responses to analgesics. Genetic factors governing COX-2 expression, genetic factors governing COX-1. So this whole area is a big new ball game, pharmacogenomics and genetics, that's going to be very much with us in the future. If we look at the variables here that that are impacting on the non-steroidals. Pharmacokinetics, which is conveniently called what the body does to the drug. As you know, as you remember from your college days, it deals with absorption, distribution, metabolism, and excretion and general disposition. And then we have pharmacodynamics, what the drug does to the body, how it acts at the biophase, how it acts at the site of action. This may be a therapeutic effect, or it might be a toxic effect. And when we look at individual variation, toxic effects to non-steroidals are well known, but the toxic effects and adverse reactions to non-steroidals, that's the spectacular end of the equation. That's the tip of the iceberg that you see. The bits you don't see quite commonly are the therapeutic variations, the bit under the water. And it's the therapeutic variations that are very subtle that we have to bear in mind. Some years ago, you remember the COX-2, the super selective COX-2 inhibitors were introduced, the COXIBs. And these came out with a blast of fanfare and trumpeting that these were tremendous safe drugs and so on. And within a few short years, Merck, Sharp and Dohme were feeling the bit of trouble because they had to withdraw Vioxx, which was one of the COXIBs, which caused a lot of intravascular hemorrhage and strokes, because what was seen to be a terrific thing at the time, COX-2 inhibition, was seen to have a downside as well, which is that the COX-2 inhibition, through the prostacyclin thromboxane seesaw equilibrium, out of kilter, and strokes and clotting occurred, and Vioxx was removed from the market. That was the spectacular end of adverse reaction in individual variations. But as I say, subtly, we have at the therapeutic end great variation of them as well. Now, just to refresh our mind without diving too much into pharmacology, remember all the non-steroidals, they're acidic drugs, they're very low dissociation constants, they're all acids, and they're ostensibly ion-trapped. In other words, wherever they find themselves up against a basicity or alkalinity in the body, they tend to localize there because they're charged. And many sites of inflammation, you'll find that these drugs pile up in different amounts, in different animals, in different conditions, different amounts. Very high binding to plasma albumin, as you'll remember as well, more than 95, 98%. And of course, the action of the drug is related only to the free form, not to the bound form. And where you get competition between highly bound drugs, one drug can push off the other one off the plasma albumin, displace it, and shoot up the free drug concentration disproportionately. Zero-order kinetics, that's where we have these drugs, some of them like phenylbutazone and aspirin, their half-life is dose-dependent, and if you increase the dose, you'll stretch the half-life, and repeat doses can stretch the half-life as well. That's different to most drugs. The side effects were alluded to this morning, I won't go into that. Central analgesic effect, that's a contentious area. Suffice it to say that originally when these were introduced, aspirin was introduced, it was clearly seen to be, amongst other things, an antipyretic. It passes the blood-brain barrier, it suppresses prostaglandin E levels centrally, and is antipyretic. Now, to what extent they are also centrally analgesic is a moot point. Certainly, some of the later COXIBs have claims to have central analgesic effects, and it's known that lots of them affect COX-2 centrally, and some of the more recent research with some of the later COX-2s is in the zone of Alzheimer's disease, where there is thought to be, not proven, high expression of COX-2 centrally. So I'll come back to that central effect of analgesia later on. So marked individual variation is the issue we see here. So if we want to look at the various factors here, we look at a PK-PD approach, a pharmacokinetic, pharmacodynamic approach. And just shooting through these very, very quickly, pharmacokinetics, we want to know how quickly the drug and how easily it gets to the biophase site of action. In what amounts does it get there? How long does it last? How quick does it act? And how long is it going to stay there? And when is it going to be excreted? Once it's at the biophase or site of action, there are also variabilities. In other words, how does it affect its effect there? How intense is its effect? What's its potency? And what's its avidity or its actual affinity for the various enzymes or whatever at the site of action? So looking at the pharmacokinetic variation, the key principle here is that the same dose will not produce the same concentration among patients because of this interpatient difference, because of these huge variations in absorption, distribution, metabolism, and excretion. And this is very major with non-steroidals. They certainly exemplify the Gaussian curve of distribution, that's for sure, where you have a mean response and then outliers here in terms of kinetics. There's great variation within the range themselves, and they're very potent drugs. The factors that will come into play here will be certainly anything that will affect the bioavailability. Drug-food interactions, as you know, diet is a huge factor with non-steroidals, whether there's hay present or not in the various types of concentrates. Drug-drug interactions, displacement from plasma protein, enzyme induction and inhibition, altered liver function, of course, where plasma albumin can be decreased and there's increased free drug binding. Then we have age, breed, and sex differences, genetics, and so on. And we're familiar here with all the differences in bioavailability that you can get, be it on a dietary issue or a formulation. Formulation comes into play there as well, don't forget, with all bioavailability, particle size, excipients, and so on, as you're familiar with. They also come into play, apart from dietary factors. The frequency of drug usage, of course, and administration as well. The frequency of drug usage. It depends how often, obviously, we administer a drug. This is the initial administration of a drug. And if we administer it subsequently at times equal to the half-life or within the half-life, we can get accumulation. That could cause problems as well, particularly with drugs which have long terminal half-lives, as phenylbutazone has. The pharmacokinetics, I said, a lot of these are highly protein-bound, and even some of them are bound to muscle protein, which is not often remembered. Even after intramuscular administration, some of them stick on to the local myosin fibers, and that can retard and give you great variations in rates of absorption and duration indirectly. The protein binding is very, very high, and this can lead to a lot of interaction. As you know, if we have drug A, let's say it's phenylbutazone, which is very highly protein bound, 98, 97%, drug B can displace it and increase the level of drug A immeasurably and can cause increased efficacy or indeed toxicity. You get this interreaction between two non-steroidals. One can displace another. There are other medications, sulfonamides and certain antimicrobials can displace non-steroidals. And also where we have liver disease or some intercurrent disease where there's low plasma albumin, this can be a problem as well, and we get a greater drug effect. The half-life I mentioned there, usually we have what's called first-order elimination kinetics in pharmacology, which means, in short, a constant fraction of a drug is eliminated. In other words, if the dose is increased, the fraction remains the same. The body can handle it and cope with it. So the half-life essentially remains the same at increasing doses. With zero-order kinetics like aspirin and phenylbutazone, the body can be saturated by the drug, if you like, and there's a constant amount eliminated. It's a saturable process, and as you bump up the dosage, the half-life increases. And that's true of phenylbutazone. Half-life is commonly quoted as 3 to 4 hours. It can go to 7 or more hours if you double the dose or increase it. Also, active metabolites come in and cloud the picture somewhat, where we've active metabolites like oxyphenbutazone, and these are active once the parent drug is being metabolized and perhaps eliminated. Now, paradoxically, some drugs with short plasma half-lives can be long-acting, like flunixin, already mentioned, because of accumulation at the site of inflammation. And that's where the action is. The action is not in the plasma. The action is at the site of inflammation, where there's binding to the enzyme. So there can be quite a discrepancy between the blood and the site of action. And how do we measure that? Influence of pH. I mentioned these are all acidic drugs which will become ion trapped in the body. And the dissociation constant, remember, the pKa is how you have half a drug ionized and half unionized. And it's very low for these. And that's the lipid-soluble fraction, which can waft its way and diffuse through tissues. The ionized portion tends to be trapped. And we know that in an acidic pH, All these drugs are mainly unionized and lipid soluble, and in an alkaline pH ionized and more water soluble. So depending on the pH of different body compartments, you get different concentrations of drugs. And you're familiar also with the fact that depending on the pH of the urine, drugs may be eliminated more quickly or more slowly in racing, as indeed in resting animals, depending on the diet and so on. There's also interaction between combinations of non-steroidals. There's an interaction where oxyphenbutazone and phenylbutazone are administered together. There can be some displacement from plasma protein. Meclofenamic acid and phenylbutazone, there can be displacement there. Isopyrin and phenylbutazone, not only is there plasma displacement there, but also competition for metabolism. And the presence of a second non-steroidal, apart from displacement from plasma, can also inhibit drug metabolizing enzymes and prolong the sojourn of the other drug, of the other non-steroidal in the body. So there's a lot of scope for interaction. The secondary issue there is wherever you have two or more non-steroidals together, not only is there this interaction, but they might be used as cocktails. That's the other issue you're familiar with, where they're used as cocktails to duck under the threshold radar of detection. But pharmacologically, they will interact as well. Enzyme competition or plasma protein. The plasma half-life as well is off-quoted. Now, what is more germane to us is to know how much drug is actually in the joint, because that's where it's all happening most of the time. So the extent of absorption, the plasma protein binding, metabolism rate, pH of tissues, that's all going to govern the trapping of the drug in the joint. And these are acidic drugs. And quite often the joint half-life of these is greater than the plasma half-life. So the drug sticks around at the inflammatory focus rather than it might appear from the blood. So it can be, you can have a low level in plasma, but there can be quite a discrepancy in the joint. So duration of action in the joint will depend on the amount of drug that gets in there and its binding to the enzymes. And obviously the pathology of the joint is relevant as well. Another issue, I won't delay on this one, but just to mention it to you, is chirality, which occurs with some of the non-steroidals, now not with phenylbutazone. This is from the Greek word for a hand. This is isomers, as we would call them formerly, or enantiomers, is that some of these drugs exist as racemic mixtures, as racemates like ketoprofen, flurbiprofen, carprofen, and so on. And they have an S isomer, which is the active form, sinister, meaning left, or the L isomer, and the R isomer, rectus, meaning right, which is inactive. But essentially, with this class of non-steroidals, these cloud the picture even more because you're talking about two enantiomers, which are handled differently in the body in terms of kinetics and possibly pharmacodynamics as well. Because the kinetics of these can be quite different. It's been shown with carprofen that some of its enantiomers penetrate the central nervous system quite well, and has been suggested perhaps that some of the analgesia due to carprofen is due to that central permeation by one of its isomers. Pharmacodynamic, that's just hitting in spots the pharmacokinetic variables. The variables at the site of action, well, as I say, what's going to determine what gets it to the site of action is the amount of drug and plasma at the site of action, or the biophase, the escape of the plasma-bound drug, and the escape of the non-plasma or the free drug. The pKa, how much is ion trapped, that's going to depend on the local pH. Its avidity for COX-2 enzymes, the duration of binding to COX enzymes, and how selective is it for these as well. In short, most of the non-steroidals, and it's a dangerous generalization, but they have the same qualitative action. It's the keystone is COX inhibition for sure, but there may be other activities as well. The greatest differences are quantitative on kinetics, all these issues here that I mentioned, bioavailabilities, metabolisms, metabolites, enantiomers, and half-lives, and so on. However, we get this concentration at the inflammatory site, which can vary quite a bit. And here you're down to the intrinsic potency and the duration of drug action at the site. And this is going to vary. They're not all the same at the biophase. The local COX enzyme affinity will vary here. And this is just to show you, if this is the COX-2 receptor here, The binding avidity varies for different non-steroidals hugely. And there are many tables published in the literature showing numerically all the different avidities for these COX-2 enzymes on a comparative basis between the non-steroidals. Now, this expression of COX-1 or COX-2, you're familiar with the selectivity that there may be for COX-1 or COX-2, but that expression can vary. COX-1, COX-2 expression is genetically determined. That's why there's such individual response. And also the intensity of the drug binding to COX-2 will vary. And also the duration to the binding of COX-2 will vary. And this is the priming pump of the effect of the drug. So this binding avidity can vary here with all of these COX-2 inhibitors. The inhibitory constants for COX-1 and COX-2. As I say, there are a lot of tables of numerical comparisons here, and I didn't want to bore you by putting up all these numbers, because we might all self-destruct in a cascade of femtograms and picograms and everything else. But the inhibitory constants for COX-1 and COX-2s, it varies between individual animals and within individuals. In other words, to what extent they're going to latch on to COX-1 or COX-2. And it doesn't necessarily correlate with the plasma levels. That's important. Each drug is quite different. Each non-steroidal is different. For instance, Peter Lees showed, amongst his many fine papers some years ago, that phenylbutazone levels in cattle, 15 times the horse plasma level, 15 times the horse plasma level, produce less COX-2 inhibition in cattle. So 15 times the dose, the horse dose, less inhibition. So obviously COX affinity varies hugely for individual drugs and across species quite clearly as well. So there's not only a huge variation in the amount of drug getting to the site of action, but the local intensity. And this is compounded by the grey area here, the variable effects in the CNS, which could cause further analgesia and loss of pain perception. As I say, that has been shown for the recent COX-IBs. It certainly was not ever deemed to be the case with the earlier COX-1 non-selective inhibitors, but certainly we know that the blood-brain barrier is passed by these drugs. Just to get to wrap up, individual variations, which COX is going to be affected here? The variation of COX-1 and COX-2 ratio from patient to patient, the higher susceptibility to toxicity in animals. Some patients have weaker therapeutic responses, all due to this inherent difference genetically determined on COX-1 and COX-2. So, genetic mediation of these analgesic drugs is big business now, and it's certainly been shown that a lot of the individual variation here has to receive further study. And as I said at the outset, pharmacogenomics and genetics, big issue here in looking at the individual variation. Half-lives, just to retouch on that briefly, the short half-lives and the duration can be much longer because the half-lives at the site of the exudate is much longer, and that's true of flunixin, ketoprofen, and so on. Isomers, these can exist locally, and these can also accumulate at the site. In summary, I just say that the last slide here, the tissue levels of non-steroidals are the result of a number of complex simultaneous dynamic processes which vary greatly from animal to animal. And when the drug reaches the tissues in those highly variable amounts, the avidity for COX-2 and the duration of its binding is highly variable. It's not one size fits all, as I said at the start. The release varies, the intensity will vary. Passage into the central nervous system and elevation of pain threshold of the COX-IBs, that's highly variable. And certainly a low level of non-steroidal in the plasma does not necessarily indicate the absence of a significant anti-inflammatory nor potent analgesic effect. And in my opinion, performance could be affected or perhaps beneficially restored at low levels in horses which have some subliminal anti-inflammatory problem and which are receiving a non-steroidal. Thank you.